The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, back with Shaun Mendenhall, who has been talking to us this month about issues related to hands. He's a great hand surgeon, and here for a Q&A. You ready to field some questions, Shaun?
Absolutely.
Before we start, do you have any conflicts to disclose?
Yes, so I'm an educational consultant for PolyNovo, which is unrelated to our discussion today.
Okay. Question number 1. This is really more a prevention question than anything else, but it's something that I think has implications both for your practice and mine. Do you have any tips for dealing with nail biters?
You know, that's a good question. I think many of us as physicians and as parents have had to deal with this at some time or another. You know, this is a little bit more of a behavioral thing and not necessarily a surgical thing. So I don't have any major, tips to help with that other than just lots of counseling and encouraging kids to not bite their nails, as it can lead to a lot of issues. My sons are both basketball players, and so if they bite their nails too short, they get the split nails, where just this hyponychial skin separates from the nail and it causes a lot of pain and complaining. So that's been a good deterrent for my kids. And then rarely it can lead to infections, like paronychias. But yeah, unfortunately, I don't have any major groundbreaking tips on how to prevent that other than just good encouragement and counseling.
I'm always on the hunt. So just along those lines with your sons, how do you deal with those splits?
It's really hard when they're athletes and they just have to continue playing. There's a lot of trauma to the fingertips, especially in basketball and football. So when they get really bad, we just put a little bit of antibiotic ointment and a Band-Aid on them and encourage them to try not to use it. And I've had even some patients that get a chronic split in the skin, not necessarily right at that junction, but in the skin. And the only way to get that to heal is to stop playing for a while and even put a little cap splint on the end of the finger. And I've even tried, a minor operation to just excise the chronic little wound and suture it up and then glue it a lot with Dermabond. And that has been somewhat helpful, but also not a complete cure. So the biggest thing is just taking time away and letting it heal.
That's tough, especially since basketball is a winter sport, and it seems like that the cold weather, also the dry weather, is one more factor.
Yeah, it is.
All right. Next question. Along those same lines, how should I approach ingrown fingernails, paronychia? When do they need something more than local care and maybe an antibiotic?
Yeah, this is an interesting question. I typically don't think about fingernails becoming ingrown. That's more of a toenail thing because of the constant pressure on the feet and the toes. So we almost never see what's truly an ingrown fingernail, but we do see paronychias a lot, and maybe those terms are used in the primary care setting as interchangeable. But a paronychia is just anytime you get an infection around the nail fold itself. And if it's just a minor cellulitis, which most of them start out like that, just a little bit of red and soreness, then those are very amenable to oral antibiotics. When they start to become a problem is when it turns more into an abscess under the nail fold, or the infection actually gets under the nail plate itself. And those are the ones that require some type of surgical intervention. And the best treatment for it when it gets that bad are certainly, if it's early and it's minor, oral antibiotics. You can try some warm water soaks, with warm soapy water is typically what we recommend. But if there's a lot of pus and you can see it around the nail fold, then what we do surgically is we do a digital block to numb up the finger completely And then we'll remove either that part of the fingernail or the entire fingernail, and that lets the infection completely drain out. And then we do continue to do soaks twice a day with warm soapy water and then a non-stick bandage until it heals and the nail grows back.
Do you have a particular recipe for a soapy water soak?
I typically, if you can get it, I recommend Hibiclens soap. So most pharmacies have Hibiclens, or just any type of mild soap is fine as well. It doesn't necessarily have to be an antibiotic type soap, but I like Hibiclens a lot, and it's pretty available, whether it's on Amazon or pharmacies. If you don't have access to that, then just any type of mild soap that doesn't have a lot of fragrances in it. Some people like to use dilute peroxide, and that's okay 1 or 2 times, but it becomes very, very irritating to the skin if you continue to use it more than a couple times. It really dries the skin out. And so I don't recommend using it more than once or twice.
Does the temperature of the soak matter?
The temperature of the water?
Soak? Yeah. Mm-hmm.
You don't want it so hot that it burns, but the warmer it is, the more it dilates the blood vessels, brings blood flow to the area, and then that also really encourages drainage. So you want it just warm, but comfortable, not too hot.
It's not a punishment, it's a treatment.
Yeah, exactly.
Okay, next question. You mentioned the fingernails should be replaced when possible when treating a nail bed injury. What's the best way to deal with the process of losing a fingernail? The new nails growing in and pushing out the interrupted distal part. How should I deal with that?
Yeah, so a lot of times when a nail's been removed to repair a nail bed and replaced, it's going to fall off at some point, and sometimes it happens earlier than later. And if the nail plate does come off early, the nail bed that's exposed is a little bit sensitive, and so I just recommend doing lots of antibiotic ointment early on to keep it moisturized and free from sticking to the bandages. But if the nail sticks back down, a lot of times it will just get slowly pushed out by the new nail. If it gets to the point where it's catching on a lot of things and it's flipping up, then that's when we recommend just kind of taking it off. And it's easiest after a soak to take it off, whether it's a shower or bath or even just soaking in a little warm water for a while. That will soften everything up, and then the nail can just be peeled off.
That sounds painful. Next question. And the next two questions, I think, have to do with the fact that we use our hands a lot. By using our hands, we put them in danger a fair amount. How do you deal with splinters and foreign objects working their way under the fingernail?
Oh my gosh, this is probably one of the most painful things that kids can go through is if you get a big splinter under the nail. So in that particular scenario, I really recommend a digital block. So the way I do a digital block typically for the distal finger is I do a single stick with a 27 gauge needle. So smallest needle you can find, sometimes even a 30 gauge needle. And I do it right at the palmodigital crease over the flexor tendon. So I'm right in the center of the palmar finger. And what I'll do is I'll infiltrate, depending on the size of the kid, anywhere from 3 to 5 cc's of 1% lidocaine. And it can be plain or it can be with epinephrine. It is an old wives' tale that you cannot use epinephrine in the finger. It has now been demonstrated to be totally safe. So if I want the local anesthetic to last longer or to slow down any bleeding, I use epinephrine all the time. And I just slowly infiltrate that there, and that will go around both neurovascular bundles and even percolate around to the back of the finger, and that will numb up the finger really well. And once it's numb, then if you have a piece of the splinter, at least grabbable, you can grab that with some little pickups or tweezers and just slide that out. Typically, I'll do that and I'll just look really close. And many times I'll even use a little finger tourniquet, like I'll use a little sterile glove finger if I need to, just to squeeze all the blood out and wrap that around the finger. So then when I pull the wood out, I can look and see if there's any left behind. And if there's wood left behind, then that requires removing the fingernail and getting the wood out of there, because you don't really want to leave any pieces of wood in the nail bed. And most of the time they just come right out and you're good and you don't have to remove the nail. But every once in a while you do have to remove the nail to get it out more.
Let me go back to just a couple of things, because I think there were a couple of points you make about a digital block that I think bear repeating. So number one, it's a single palmar injection.
Correct.
it's a fair amount of lidocaine, so 3 to 5 cc's,
Yeah.
and with epinephrine is okay.
Yep. Yeah. So, the old way is to do 2 injections in the web spaces.
Yeah.
And that is so painful. And palmarly, it's painful as well. The palmar aspect is very sensitive, but when you do one stick, it is so much better than anticipation of that second stick. And what I'll often do, just to make it a little bit better, if I'm in the office, I'll use ethyl chloride cold spray right on the spot first. Or, if I'm in the emergency room or something and I can't get ethyl chloride, I'll just get some ice and I'll hold ice right on the spot that I'm going to inject. And I'll tell you, it makes a tremendous difference to just really, freeze up that little area first. And a lot of times you can, they just barely fill that poke for a second until the local starts going in.
Well, consider my mind blown because you're exactly right. Getting that second injection that's a negotiation because the first one was so fun. Let's do another one. So that's great. The next one I think you've already sort of answered with the more minor injuries, but how do I care for a deep abrasion on the finger? So the kind where dealing with power tools or kitchen tools or those sorts of things, we see these, I think, more in adolescence, but the kind that leave a great big crater on the end of the finger, not enough to think about reattachment, but enough to be a real management issue because, again, you're going to be using your hands. What do you do with those?
Yeah, another great question. This is one that we've really evolved a lot on how we treat these. We used to be fairly aggressive with doing these little flaps and skin grafts and things like that to the fingertip. But a small avulsion of tissue, we have learned if you just treat that with dressing changes. And what I mean by that is you can just use some Aquaphor Vaseline, 1 to 2 times a day. Just gob it up and then put a non-stick dressing over that. These heal up so well on their own. And what we've learned is the sensation that comes back with secondary healing of these wounds is actually much better than when we did skin grafts or little flaps. And so, my preference is, since I have access to these things, is I do, again, just Aquaphor and then a little Tegaderm, because Tegaderm doesn't stick, so it doesn't hurt when it comes off. And then I'll wrap up a little Coban over that. There's actually some really nice papers in the hand surgery literature by a Canadian surgeon named Don Lalonde. And he just would do lots of Vaseline and Coban directly over the Vaseline and had incredible results with quite significant wounds. So just keeping it moisturized, doing a non-stick bandage so it doesn't hurt, and after a few days, the sensitivity goes down and it becomes less painful in general. But so anyway, good just wound care. Wash it with soap and water, lots of grease, whether you like Aquaphor or early on a little antibiotic ointment is fine, but you don't want to use antibiotic ointment too long. A lot of people have sensitivities to Neosporin, so we don't use a ton of Neosporin. So we think of more bacitracin, but just plain old Aquaphor Vaseline is sufficient most of the time.
Very helpful. Next question. We're in Utah. It's winter. What can you tell me about skier's thumb and how should I treat it?
When you said we're in Utah and it's winter, I thought you were going to ask about frostbite.
Well, let's ask about frostbite then. Save that. That's the next question.
Okay, so for skier's thumb, so this is when a young skier crashes and their ski pole creates this strong abduction force on the thumb, and that can injure, either partially tear or completely tear, the ulnar collateral ligament of the thumb MP joint. And that can be a problem. So this is something that certainly needs x-rays. And if the joint is lined up, it needs a thumb brace, so a thumb spica splint of some sort. And then certainly they need to come see a pediatric hand specialist to make sure it's not a complete tear of the ligament. Most commonly, they are partial tears of the ligament, and that just requires sometimes a cast and then a splint for, on the order of 6 to 8 weeks to let the ligament heal. If it's a complete tear, that often requires surgery to repair that. And we can tell oftentimes as hand specialists on our physical exam whether or not it's a partial tear or a complete tear. And if there's any question, I typically order an MRI, and that will help me answer that question if I just can't sort it out on my exam.
And as with all the other things we've dealt with, consulting with someone like you is a good thing.
Yes, absolutely. Especially these more severe things. I mean, really, all of these things I think are great to consult with us, and that's what we're here for, is to take care of any and all hand type of conditions. But yeah, certainly a skier's thumb should be evaluated by one of us.
Well, the next question. We're in Utah and it's winter. How should we deal with frostbite? Because, it gets really cold and kids don't necessarily use a lot of good sense in being out in the cold.
Yeah, so what frostbite is frostbite is when the skin has actually been cooled down so much that the tissue starts to die. And what happens is first you get vasoconstriction, where the blood vessels just really slow down the blood flow to the area, and that's obviously to protect the core body temperature. And then what happens, you start to get, crystallizing of the intracellular and extracellular fluids. And what it looks like immediately is it's often very red, sometimes blistered, and then it slowly turns black. Again, this is rare and just, sort of day-to-day normal stuff. But if people get stranded out in the cold for a while, or if they're out, snowmobiling for a really long time and ignore the pain that comes with being so cold in their fingers, then, the tissue can die. Typically, it's one of those things where we just watch very closely and allow the tissue to do what it's going to do. If it's really severe, then obviously coming into the hospital, we have a whole protocol in the hospital on how we can actively rewarm and try to get the tissue up to a good temperature and see how much of it's going to be salvageable. Worst case scenario is you lose a little bit of skin or a fingertip, on these more minor type of scenarios. We do sometimes see patients who have had these horrific experiences where they've been stranded, and those scenarios, or even people that suffer from homelessness and things like that, we can see it where it's entire fingers or even hands or feet. But yeah, if there's any question, if there's a lot of blistering, redness, good non-stick type of bandage, and then consultation with us as soon as possible is helpful.
Excellent. Last question. Hands are, as with really all of our parts of our body, where we have to do where we do repetitive things. And I think in athletics, especially where people specialize and are often doing something year round, I get this sense that we see a lot more overuse injuries than we maybe did before. How much does warming up and stretching help in preventing overuse injuries of the hand? And when I'm doing pre-participation evaluation and counseling, what sort of prevention should I be emphasizing?
These are both some interesting questions. I think it's always helpful to warm up and stretch before you do any major sports activity. I don't know, to be honest, how much that prevents injury. I think what prevents injury is not going from 0 to 100 miles an hour right away. So if you're going to be a competitive athlete, you don't want to just jump right in and do something you've never done at full strength. You want to slowly work up to that and let your body, your muscles, your ligaments, your joints sort of get used to that pattern of use and strengthen themselves before you just jump right into something. So I think it's a long-term warm up or build up or strengthening that's probably more important for preventing injuries than just a quick little stretch and warm up. But I think nonetheless, both are likely important, and just letting your body do what it was meant to do, and that's to adapt to the environment. So, for example, just to give you a personal example of this, I grew up doing quite a bit of martial arts, and there was a time where I sort of stopped doing it, and then I went kind of right back at it very quickly with doing some kicks and things like this on a heavy bag, and I injured my hip doing that because I had just gotten out of the pattern and out of the condition and the shape to do this, at that level. And so going from 0 to 100, obviously was not good for my hip.
Excellent point. And do you recommend before kids get on their phones in the morning that they maybe go through a warm up period so they don't?
Yeah, that's right. Little active range of motion of the fingers before they start texting like crazy.
Well, Shaun, this has been very, very, very helpful. Thanks so much for your time and expertise. As we were talking a couple of weeks ago before we started recording the original episodes, there are so many more topics we can talk about, and I hope you're willing to come back at some point for us to learn some more.
Yes, absolutely. I think I'd love to come back and talk about cerebral palsy and all the new things we can do to help kids with contractures of their hands, arms, legs with that. Certainly nerve injuries and brachial plexus birth palsies and things like that we could talk a lot more about. So that would be a lot of fun to come back.
Let's plan on it. And just to shout out to you, as people have listened to the episodes and as I've talked about this in the last couple of weeks, there have been so many people who have said, oh, he has been so great in guiding me through stuff with my patients. Apparently, you are fielding a lot of calls, and we all appreciate that very much.
Yeah, well, so happy to be of help to you and your partners and your patients. And certainly if any parents or providers want to get a hold of me about a hand issue, you can call us at our office in the University of Utah Plastic Surgery at 801-581-7719. Or certainly you can ping me on Instagram too at PedsHandDoc. And I try to check that with some frequency. So if you have any questions or something, you can reach out to me there.
Perfect. Thanks so much. And thanks to our listeners. Make sure and tell your friends and like and subscribe, and we'll talk next week. And Shaun, we'll talk in a few months.
Great. Thank you so much for having me.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.